हाय फ्रेंड्स, गुड इवनिंग। I'm डॉक्टर आशुतोष और आज बात कर लेते हैं ऐसी एक लीजन के बारे में विच वी बिलीव इज अ बिनाइन, राइट। सो अर्लियर वीडियो मैंने बताया था कि माइक्रोग्नेथिया है विच इज ऑलमोस्ट ऑलवेज एन ऑमनियस फाइंडिंग एंड कम व्हाट मे व्हाटएवर टेस्ट दैट वी डू एंड the it is a sinister finding. Now on the contrary, what I'm trying to tell you now is this lesion which is there in the lung. It might sound sinister but it is very benign, right? So many times we identified that there could be some lesion in the lung and which is slightly ecogenic as compared to the liver, or it is definitely intrapulmonary because वो diaphragm के ऊपर है और extra pulmonary नहीं है. Extra pulmonary meaning thereby that it would become a pulmonary sequestration, and mostly 65% of the cases में ऐसा होता है कि वो सब diaphragm के नीचे होता है. So it is there in the abdomen. Lung tissue is present in the abdomen but not in the thorax. So the lesion that we are talking about, it is definitely intrapulmonary and it is a part of the lung. Mostly left parabasal lung में पाया जाता है and it is slightly hyperechoic and ecogenic as compared to the other lung parenchyma, right? Secondly, the right lung has got three lobes and the left lung has got two lobes, right? So meaning thereby that this is an hematomatous lesion. It is a benign lesion, can occupy one of the a complete lobe of the left lung, and then how do we follow it out across, and how do we see, and how do we prognosticate, what how do we counsel and what to counsel. This is probably we will see successively, right? So this is the ultrasound that we are doing at the anomaly at the 20 weeks, and then we can identify that this is white lesion which is there in the lung. It is a left posterior basal sort of a small lesion which is hyperechoic into the left parabasal left lung, and this is microcystic CCAM, right? It is a CPAM, and it is very small and something around 1.1 into 1.1 millimeter, and we just identify them to be normal finding until unless they involve the whole of the left lobe, lead to dextrocardia, and therefore we can have. So how do we identify them is by doing a CVR ratio, and therefore when the CVR ratio is greater than our cutoff, and therefore they are more prone and sinister to create hydrops and to create a mass lesion, as a matter of fact, right? But then this is a sort of an incidental finding. We identify to be an hematomatous lesion which is benign in nature and can grow from 18 to 26 to 28 weeks, and then it plateaus, and then in 10% of the cases might even regress. Okay, so this is just a normal finding. Unlike fetal micrognathia, which we identify it to be an omnias, once we identify that the micrognathia is there, it is almost always omnias. Similarly, this CCAM lesion, it depends upon its size, which is very small. Even though it can be identified in 1 to 2% of the cases, we identify that they might even grow up to 24, 26 weeks. From 26 to 28, 30 weeks, they plateau, and in 10% of the lesions, 10% of the cases, what we identify that the lesions might even disappear successively as we move on from 32 weeks. Okay, and the third thing is this, that since they increase, they can have a mass effect, and they can have a, and therefore they can press upon the inferior vena cava or the venous return to the heart, can lead to hydrops. So for which we do have a CVR ratio by which we monitor these cases, right? And this could be, since it is very small, the close differential diagnosis that we are dealing up with is a mucus plug. So at the terminal bronchiole in the left lung can get obstructed because of the mucus plug, and as the baby grows, the diameter of that bronchiole would also increase in the diameter, and therefore the mucus plug, the baby is able to expel it out, and is able to cough out that mucus plug. So similarly, as the baby grows at 32 weeks or so, we identify that these lesions, they might even disappear, right? Okay, even though they are there, they are benign. They are more prone for infection. So probably after the baby is born, the baby would need surgery. No, the baby would be cyanotic. The answer is no. Whether the baby would be blue, the baby would have a respiratory difficulty. The answer is no. Uh, How and when the baby can present is this, that they can definitely be a nidus or an infection. So the baby, if the baby is having this respiratory infections and pneumonias very recurrent and not responding to antibiotics, and every quarterly, every 3 months we identify that probably the baby is falling sick, baby is needing an IV antibiotics and all those stuff and hospitalization, and therefore in those cases we might need to do that lobectomy, in which we probably take out that small lesion. The remaining space which is being available, by removing that lobe, the healthy remaining left lung expands and therefore occupies the whole of the space. Okay, so there is hardly anything to get worried of. Yes, definitely the baby might need a surgery because it becomes an itis of infection, but not in the antenatal period, not in the immediate postnatal period. So it is sort of an finding that probably we identify. So probably we need to just keep a close watch to the baby after the baby is born, like 3 months, 6 months, more prone for respiratory infections and pneumonia, for which we probably can guide them and all those stuff, right? Antenatally, if it is occupying the whole of the lesion, it is creating dextrocardia. The CVR ratio is greater than the cutoff values, and therefore it is more prone to create hydrops. That hydrops can happen at something around 26-28 weeks, when we identify that it is that has got propensity to increase, to increase in the size and all those stuff. It really doesn't happen greater than 30-32 weeks. By that time the lungs, they are expanding, the chest is also expanding, and therefore it really doesn't have that mass effect normally, and therefore, so this finding might look sinister, that probably we are having some lesion in the lung and therefore the baby might have some difficulty and all those stuff. But it is not the case. It is just a normal finding, and a reassurance is being required. Definitely the baby would need a surveillance, but a routine surveillance which we are doing, we are not doing in any extra surveillance for this lesion, right? So reassurance is the key, right, for this lung lesions. Thank you very much for your patience.